Hey there, everyone. Naveen Nathan, Assistant Professor of Anesthesiology here. I'm going to move on with our lecture series on physics, machines, and monitors for the advanced exam. And in this lecture, we're going to cover invasive monitoring. It's a little bit unclear. The ABA actually includes invasive monitoring in both the Part 1 basic exam and the Part 2 advanced exam. A little bit more emphasis on arterial line monitoring for the basic exam, and more of the emphasis on central invasive monitoring for the advanced exam. Either way, I'm going to cover the broad scope of all of these. And, certainly worth, I think, reviewing your notes from the Part 1 exam on invasive monitoring. And if you have access to that lecture, I think it was lecture number 8 on physics from the Part 1 exam, it's worth reviewing that as well. A lot of this will be redundant, but given the uncertainty of where the questions are going to come from in this keyword, I wanted to be comprehensive. So definitely look at those notes from the first Part 1 exam and the lecture from that section as well. So again, it should be worth noting where invasive pressures occur in their waveforms respectively to the electrocardiographic events that occur with the ECG. Okay, so look over this slide, spend some time studying it, and know, particularly with central monitoring, like with the CVP waveform, where the A wave occurs relative to the EKG. And you can see, of course, there's a little bit of delay right after the P wave occurs with atrial depolarization. You get atrial contraction. After the QRS and ventricular depolarization, you get ventricular contraction, and so forth. The arterial line, again, I'm not sure how much they will ask about this relative to central monitoring for the advanced exam, but just to review, you have systolic upstroke, peak systolic pressure, a decline with a dicrotic notch, and then diastolic runoff. And there's a delay of about 180 milliseconds between the R wave on the EKG and the upstroke of systole on the radial arterial line, because of course there's delay in the wave front entering the catheter tip. And reviewing generalized principles of invasive pressure waveforms. As you progressively get further and further away from the central pump, your waveform adopts a lot more ringing and resonance because of all the wave reflections that have bounced back and forth against arterial branch points, and then summate to basically create a lot of oscillation and resonance in your waveform, especially all the way when you get down to the dorsalis artery. You get a systolic overshoot as a result of that. Okay, and so the aortic waveform, that gives you actually the most faithful portrayal of what a natural arterial waveform should look like, in the absence of a whole lot of resonance, because obviously the aorta hasn't branched off yet. And you all know this, the catheter, fluid-filled catheter systems basically have a pressure bag filled with saline and a contiguous column of fluid directly in continuity with the artery that you're monitoring. And therefore, the transducer diaphragm, which lives right here, essentially interprets this fluid column as basically an extension of your artery. For all intents and purposes, the transducer thinks this is directly the artery right here, because it's a contiguous column of fluid. And essentially you have what's called a Wheatstone bridge inside here with a series of 5 resistances, one of which is unknown, and with deformation of this diaphragm that gets bombarded with pulsatile wave fronts from your patient's pulse, which is attached to that 5th resistance, it induces deformation of that membrane, which alters the resistance in that circuit and creates a current, and that is transposed into an electrical signal, which ultimately is processed into your arterial waveform. Okay, and that's the basic principle behind these transducers. And you'll see this frequently in a variety of different anesthesia textbooks. It's the concepts of damping and natural frequency. And if you recollect from my lecture from the basic exam series on physics and monitors, frequency, this natural frequency, this is a property of anything in the universe. The more homogeneous something is on a molecular level, the more it has a natural frequency that can be observed. A good example is the steel or metal of a guitar string. It rings, and in the case of guitar, it's a good example because both the low bass string and the high treble string are both set to the E note, meaning one is just simply multiples of the other in terms of its intrinsic natural frequency. And so when you pluck one string, the other one will start to oscillate on its own without ever being touched. That's the concept of resonance. So everything in the known universe has something like this. Of course, when you're comprised of lots of different materials, such as, for example, biologic systems made of bone, calcium, water, plasma, all sorts of stuff, it's pretty hard to define what the natural frequency is there. That said, anything that reoccurs repeatedly at a regular interval does produce a frequency. So even though we're made up a lot of different things, the one thing that human beings do that creates a fundamental frequency is our heart beats, and it generally beats along the same clip until you get to a point where you become tachycardic or bradycardic, of course, but for a certain stretch of time, your heart rate remains unchanged, and let's say hypothetically your heart rate is 60, that's 60 beats per minute. That's one beat for every second, and since one beat for every second is the same as one cycle per second, that's 1 hertz. If your heart rate is 120 and you're tachycardic, that's a heartbeat, 2 heartbeats per second, that's 2 hertz. So that's the most obvious example in a biologic system in a human being, in a patient, of how we produce a fundamental frequency. It's not so much related to what we're made of, in terms of our molecular makeup. It's the fact that we have a beating pump that occurs cyclically with regular frequency. And the problem is that when we're doing that with our heart and we're attached directly to a catheter system that's monitoring our arterial waveform, the catheter system itself has its own natural frequency, which is in the range of about 15 hertz. And so when we're producing our own fundamental frequency of 1 to 2 hertz, and we're attached directly to a system with its own natural frequency, if the frequencies of the two systems, our heart rate and the fluid-filled catheter system, start to overlap, they will be ringing. Now, you might think that, well, that's not a problem because since our heart rates generally go from 60 to 120, we're only at 1 to 2 hertz, we're not overlapping with our monitoring system. It's not a problem, but we actually do overlap because we typically monitor arteries that are in the periphery, like the radial artery. By the time you get down to the radial artery, there's a lot of wave reflections that have occurred from all the branch points in the arterial tree that summate to create high-frequency components of your arterial waveform. Those are the components of this upstroke right here. And that brings the biologic system, the patient's body, into range, that arterial pulse range, the frequency range, into the same range as the natural frequency of the catheter-based system that's monitoring it. So there actually is some overlap, and the two will ring, and what you'll see is essentially what's called an underdamped waveform. You get higher than normal systolic. There's a lot more oscillations there. And so catheter systems are designed with a certain degree of frictional forces, that try to bring the ringing down to rest, and that's what's called the damping coefficient. That's reflective of the frictional forces that define how quickly the system comes to rest, like the brakes on a tire, And so when you have optimal damping to reduce the excess amount of oscillations, you're in this range, in adequate dynamic response. Which basically says that you have optimal damping relative to the amount of oscillations in your fluid-filled catheter system, and the waveform that you're getting for your art line is relatively accurate, an accurate measure and reflection of the true arterial pressure in the patient. So that's what that all is defined by. That's what that means. So again, I go over this in the Part 1 basic exam material as well, but I wanted to review it so you have a refresher course, so to speak, on that concept. If you're curious how well damped or how underdamped your system might be, you just do a fast flush test, which basically means you pull the flush on your art line, goes to 300 torque, because that's what your bag is set to, and let it go abruptly, and you have about 1 to 2 oscillations, maybe 3, your system is optimally damped. If you have 1 to no oscillations, then your system is overdamped. If you have 4 or more, you are underdamped. And again, this image from Miller's anesthesia is reflective of the concepts of hydraulics that are at play with invasive arterial line monitoring. When you raise your arm up in the air, you're losing hydrostatic pressure in the arteries. And therefore, if you measure with a cuff, your blood pressure will be lower than what it is everywhere else in the body, okay, relative to the heart, because you lost hydrostatic pressure because your arm was raised above the level of the heart. But you gain all that hydrostatic pressure back with your fluid-filled catheter tubing all the way down your transducer if your transducer is still at the level of the heart. So even though you lost that hydrostatic pressure going up, you gain it back coming down, and therefore your art line pressure will remain normal. And lastly, there are significant differences in art line waveforms between young and elderly patients. Elderly patients, the vast majority of them have diastolic dysfunction and a calcification of their arterial tree, which basically reduces the compliance of their arteries and their blood vessels in general, and therefore small changes in volume lead to large-scale changes in pressure. So elderly patients tend to have a higher systolic and a lower diastolic compared to younger patients. Not because they have essential hypertension. If they're otherwise healthy, they will still exhibit this waveform due to the normal process of arterial aging and thickening and calcification. And there are also waveforms that are abnormal related to pathophysiologic states. If you have a patient with aortic stenosis, you're going to see this delayed upstroke and loss of morphology on your art line waveform. Regurgitant lesions tend to give you a Bispherians type of waveform. And, other pathophysiologic states such as constrictive pericarditis and things like that, decreased ventricular compliance will give you a spike in dome appearance here, you see. Not sure if they'll really get that detailed in terms of giving you these waveforms on the exam, but I put those in there. These are from Miller's anesthesia just for your own curiosity. When cannulating the radial artery, you don't necessarily need to take into account the results of the Allen's test. It's not predictive of ischemia risk. There's really old literature that shows that, if you have a positive Allen's test and you don't have collateral flow, you can still do an art line, and it doesn't seem to increase the risk of complications from the art line. You might take caution with it, but it's not absolutely predictive of ischemia risk. Most patients are radial dominant. Remember that. You actually cannulate the radial artery in most patients when we need an art line, so that it is somewhat ironic. And the risks of ischemia, aneurysmal formation, fistula, embolization, especially with air as you use the flush, infection and neuropathy exist with the placement of art lines invasively. So we're going to move on to invasive monitoring. You see here is an anatomic image of the blood vessels of interest when you're doing central venous cannulation, especially in the internal jugular vein. And of course, these days we almost always utilize ultrasound guidance to aid in the placement of our central venous catheters. It's usually placed in an effort to show not in plane but out of plane placement of the anatomy. And what you get is a cross-sectional view of your anatomy of interest, which of course includes your carotid artery, typically medially placed relative to your internal jugular vein. Overriding it is this muscle called sternocleidomastoid, of course. Okay, you may or may not see the vagus nerve in some cases as a bright hypoechoic small dot within the carotid sheath in some instances. Of course, as you depress your transducer, you can actually compress your internal jugular vein. So if you're applying too much pressure, you may not see anything at all. Of course, the artery is not compressible typically. This is your thyroid gland over here. Okay, this is your transverse process of cervical vertebra, sternocleidomastoid, of course, longus colli, and prevertebral fascia. And in this case, what you see is guide wire placement within the internal jugular vein correctly placed here, and you see the in-plane view with the wire coursing through the internal jugular vein. So I get used to ultrasound images as much as possible, wherever possible, for the ABA exam. They are including more both static and dynamic images, even animations, a lot more so these days. Try your best to look for abnormalities in images, whether that's chest x-ray, ultrasound imaging, CT scans. Okay, what you see here is an enormous thrombus sitting inside the internal jugular vein. Okay, the carotid artery is patent, but there's this large thrombus here, and here you see the longitudinal view of that thrombus. With ultrasound color flow Doppler measurements, you can see that the carotid artery has patent flow, but there's very little flow at all, if any, in the internal jugular vein due to that clot. So that's what a thrombus looks like under ultrasound. Now, compared to aortic pressure, radial artery pressure exhibits which of the following? Higher mean pressure, wider pulse pressure, decreased resonance, or earlier dicrotic notch. I suppose this question should have been included a little bit earlier in the lecture with the radial arterial line monitoring section. At any rate, the correct answer is a wider pulse pressure, and this all has to do with what I described as you move away from the aorta, you get higher degrees of ringing and resonance, which leads to a higher systolic and a lower diastolic in measured arteries, so therefore you get a wider pulse pressure. Okay. The mean tends to stay the same. You get increased resonance and a delayed dicrotic notch because of the delay in the travel of the wavefront away from the heart. I did put this in here because I'm not sure where they're going to stick this question if it shows up again. From years past, they asked about the sensitivity of detecting myocardial ischemia with leads 2 and V5, and the correct answer is 80%. You can increase this to 90% if you monitor just V5 and V6, and go to 96% if you monitor leads 2, V5, and V6 together. So again, moving on with central venous catheter placement. Of course, a short list of indications for placement of central venous catheters. The need for rapid infusion of large volumes of blood or fluid, transvenous cardiac pacing, temporary hemodialysis, pulmonary catheter monitoring, so you might need a conduit for that, CVP monitoring, inability to obtain sufficient peripheral access, repeated blood sampling, vasoactive drug administration, and aspiration of air emboli. Again, I'm going to review the principles of how you use CVP or pulmonary capillary wedge pressure waveform to use as a surrogate for volume status. Okay, you're using filling pressures as a surrogate for filling volume, because what you're really trying to measure is volume, but you don't have a volume monitor, you have a pressure monitor. So you're already 1 degree removed from your ability to assess volume by using a different measurement, pressure, instead of volume. Okay, and you're under the assumption that the patient is operating over an optimum point on their ventricular Starling curve. You actually don't know where this patient is on their Starling curve. So one of the ways to use central invasive monitoring is to map out their response in terms of systemic blood pressure related to your intervention, such as giving a fluid bolus or giving a diuretic, and seeing how the patient responds accordingly to those interventions. You can start to map out where they are on their Starling curve. Okay. And so you have to also take into account the ventricular compliance state, which is influenced by ventricular stiffening, ischemia, history of compensated heart failure, and valvular structures and derangements such as regurgitation or stenosis. And then extrinsic pressures such as pressures inside the pericardium, the pleura, lungs, thorax, and abdomen, which all influence your central cardiac pressures. So overall, if you're taking the advanced exam, you're not that far away from sitting for the oral exam. Remember that when your examiner asks you about how you're interpreting your patient's volume status, if you're going to say you're going to use invasive central cardiac monitoring, it's literally only one facet of a large multilateral constellation of characteristics that you're using, such as urine output, blood pressure, mucous membranes, hematocrit, acid-base status, identifiable pre-existing volume deficits, ongoing bleeding, pathologic alterations in volume, and alterations in plasma-oncotic pressure, hydrostatics, and capillary leak that can occur with ARDS, CHF, hepatic failure, or renal failure. So you have a list of no less than 9 or 10 things that can influence your volume status, and the CVP and wedge pressure, those are just one small part of it. Definitely just to review your morphology, CVP contains your AC and V waves and X and Y descent. A wave is a result of atrial contraction. C wave is ventricular contraction. X descent is when you lose your pressure because all the blood's going forward out the right ventricular outflow tract as the pulmonic valve opens. Your V wave is venous return to the right atrium, and your Y descent is when your tricuspid valve opens and you lose your pressure because all the blood is moving forward into the right ventricle. So, going back to that concept of the Starling curve, it's literally one limb on the entire cardiac pressure volume loop, which comprises all of diastole and systole. And if this is your normal loop, you can have a variety of different types of curves depending on the kind of patient that you have. If you have a patient with regurgitant valve lesions, they tend to be dilated, and your pressure volume loop looks like this. Aortic stenosis tends to look like this. It's a high afterload with lower end diastolic volumes because that thick hypertrophied myocardium reduces intracavitary filling in volume. This yellow curve over here can represent severe hypovolemia or, in fact, mitral stenosis. It's the only valve lesion that will result in an underfilled LV at end diastole because of that stenotic mitral valve. And so what you end up with is a variety of different Starling curves. You don't necessarily know exactly which one your patient's on, unless you have an echocardiogram or TE probing. And then, of course, extrinsic pressures, like I mentioned earlier, pericardium, pleura, lung, thorax, their mode of ventilation, intra-abdominal pressure, especially if you're undergoing laparoscopy. And then global positioning of your patient. Your intracardiac filling pressures are going to change depending on, if your patient's steep head down or head up position or lateral decubitus. So ultimately, your intracardiac filling pressures are the result of ventricular compliance, so your intrinsic myocardial state, whether it's dilated or hypertrophied, pulmonary vascular resistance, valve integrity, and rhythm, in addition to extrinsic pressures, like I said, and then the thorax and the abdomen, and your actual intravascular volume, which in and of itself is related to a variety of different factors: hydrostatic pressure, colloid onconic pressure, capillary leak states, venous tone, and a balance of circulating vasodilators versus catecholamines. So there's a lot that goes into the actual number that shows up on your monitor that reflects CVP or wedge pressure. Just to review the alterations in your waveform as a result of pathophysiologic states. With atrial fibrillation, you don't have atrial contraction, therefore you don't have an A wave. With AV dissociation, the atria and ventricles may contract at the same time against each other, or the atrium may contract against a closed tricuspid valve, in which case you have canon A waves, really tall A waves. Okay, tricuspid regurgitation, again, you get that regurgitant jet that meets head-on with the returning venous return, so you get a tall V wave or CV wave. Okay. Tricuspid stenosis, again, that may result in a tall A wave, as you can imagine, because the atria is contracting against a very stenotic valve. With RV ischemia and pericarditis, you get similar things, tall amplitudes of the A and V waves, or what's called an M or W configuration. And that's simply the result of small changes in volume leading to large changes in pressure, because in both cases, RV ischemia and pericarditis, you have very, very low compliant ventricles. Afterload is directly proportional to all the following parameters, except which one? LV wall thickness, end diastolic pressure, circumferential wall tension, or radius. And this question is derived from the principles of Laplace's law. And based on that equation, you should realize that afterload is inversely proportional to wall thickness. Okay, and Laplace's law, just to review, is pressure, intracavitary pressure equals 2 times circumferential wall tension times the wall thickness, all divided by radius. Okay, and so you can overall go through the equation and see that what afterload is ultimately directly proportional to versus inversely proportional to. The driving pressure that primarily influences blood flow and perfusion of the coronary vessels is which of the following? LV systolic pressure, LV end diastolic pressure, aortic systolic pressure, aortic end diastolic pressure. So coronary perfusion pressure, any sort of perfusion pressure, is always defined by a front end pressure that drives it and a back end pressure, the low end pressure. And in this case, the driving pressure is aortic and diastolic pressure because the left ventricle is only perfused during diastole. And so the highest pressure there is going to be aortic and diastolic pressure. Your back end pressure is going to be LVEDP. In the past, the ABA has asked simply what is the equation for calculating pulmonary vascular resistance and what is the normal value. So I did put this in there. It's derived from Ohm's law, meaning a resistance equals a delta pressure divided by flow. But you need this fudge factor of 80 because if you don't put that in there, you won't get to the normal values for pulmonary vascular resistance, which is 100 to 200. And so the ABA simply wanted you to know that. Patient develops acute mitral regurgitation as a result of myocardial ischemia. Which of the following components of the wedge pressure waveform will most likely be augmented? In this case, the answer is actually D. And the reason is because with myocardial ischemia, with left LV ischemia, you can get ischemia of the papillary muscles, which coordinate the chordae tendinae to coapt the mitral valve leaflets in conjunction with each other, make them synchronous. But if one or more of your papillary muscles is ischemic, the two leaflets of the mitral valve won't coapt exactly at the same time, leading to functional mitral regurgitation during times of ischemia. So if you have regurgitation, remember that's going to meet with that V wave, that venous return coming back, and it's going to be your V wave that augments in height and amplitude. And again, similar to CVP, the wedge pressure waveform looks identical to CVP, so you have AC V waves, X and Y descent. And analogous to CVP, A wave is a result of left atrial contraction, C wave is left ventricular contraction, X descent is the aortic valve opening, V wave is venous return, and the Y descent is the mitral valve opening. So entirely analogous. And the reason why you can see into the left atrium is because when you wedge your catheter here, it creates a static column of blood where there's no flow directly to the left atrium, at least alongside that arm of the pulmonary artery. And therefore, even the smallest changes in pressure here in the left atrium can be reflected back through that column of blood directly to your catheter tip. And just to review the waveforms that you see when you place the PA cath, which I'm sure you're very familiar with, you get your CVP when you enter the right atrium, the systolic upshoot here as you enter the right ventricle because you're at much higher pressures, a diastolic step up as you enter the pulmonary artery because that's a lower compliance state. And then eventually when you wedge the thing, you'll get your left-sided CVP, otherwise known as your pulmonary capillary wedge pressure. And this is what I was talking about earlier. When you have an ischemic ventricle, you tend to get this M or W configuration because the ischemic or failing heart will ultimately be a very low compliance state in which small changes in volume lead to large changes in pressure. So determinants of myocardial oxygen demand and supply. On the demand side, we have heart rate, contractility, afterload, and preload. This equation here, Laplace's law, tension equals pressure times radius all over 2 times the wall thickness. Okay, it's just a rearrangement of the way I wrote the Laplace's law in that previous multiple choice question. That can be applied to afterload and preload here. It can be applied to the ventricle, an alveolus, or an aneurysm of the aorta, for example. It's all essentially characterizing the relationships of these factors when you have a hollow viscus, essentially. And so if you're talking about a sphere or a cylinder, your radius is there, your wall thickness is there, of course. Your pressure is the intercavitary pressure, and your tension, which sounds very similar, is the circumferential wall tension, so the shear force of the fibrils that contract against each other circumferentially around this structure. And so you also need to be aware of, sorry, the text didn't show up here, but the myocardial oxygen supply side of this, which also includes your heart rate, because supply is related to the time spent in diastole. So if you have faster heart rates, you have less diastolic filling time. But it also includes oxygen content. You need to know the equation for that, which is your hemoglobin, 1.34 times your saturation, plus your PaO2 times 0.003, which is negligible overall. Okay, and it also includes your coronary vascular tone as well as coronary perfusion pressure, for which the equation is here, aortic diastolic pressure minus LV EDP. Compared to central venous catheters, peripherally inserted arterial catheters have what rate of bacterial colonization? Greater, lower, or equal rate? So the ABA actually asked this at one point on the exams, and the concept here is that arterial catheters have equal rate of colonization, not necessarily infection, which is greater for central venous catheters, but if you basically assess all these catheters for bacterial colonization, do culture on all of them, you'll find that they have equal rates. Which of the following does not reduce the incidence of central line-associated bloodstream infections? Scheduled interval catheter changes, chlorhexidine biopatches, heparin-bonded catheters, or use of a checklist during placement. The correct answer here is going to be interval catheter changes, which do not change the incidence of central line infections. The other factors here do. Okay. Again, this was back from 2009. ABA asked a question related to this. So these are my take-home points from this lecture. Again, by now if you're taking this exam, are very well acquainted with invasive lines and invasive monitoring, and we spent a lot of time talking about this for the Part 1 exam as well. That's sort of deliberate on my part because the Part 1 exam is given well after most of you have already started subspecialties. So I think a little redundancy is okay in discussing these concepts. So hopefully you found this useful. Thanks for listening.